Hi and good morning to another lecture in hand. This is week 7, and if you look into the timetable here in this week, and due to the upcoming Easter holiday, you'll see that today we will be going through a lecture which is about Coroner 5, 7, and 9. Also on Wednesday, instead of the classical tutorial, instead of our regular tutorial, there will be another lecture here about the motor pathway lecture. This lecture, we're supposed to take this lecture in week 8, on Monday in week 8, but because of public holiday, I decided to do it on this Wednesday so that you've got the recording available, and if you'd like to revise the content over the break, you should be able to do so, because the alternative option is to do the motor pathway lecture on Wednesday of week 8. So I thought that it will be here much better, so you've got access to the recording over the holiday, and then we can have a tutorial covering both week 7 and week 8 contents on Wednesday of week 8. All right, and this has been reflected here on the PAN LMS. Is someone was okay? If you've got any question, feel free to ask. You can unmute and talk, or you can post your question on the chat. So you can see on the PAN LMS page on week 7, we've got 2 lectures, one on Monday, one on Wednesday, while there is no class or workshop on Friday, okay, to fit with the scenario. Is this clear for you? Do you have any question about the schedule for this weekend, week 8? Okay. Let's start with the lecture today. So today's lecture is about cranial nerve 5, 7, and 9. You will see that this cranial nerve this lecture have been specifically scheduled between the somatosensory lecture, which have been done last week, and the motor lecture, which will be done in the upcoming week. And the reason for this is because these 3 cranial nerves have both motor sensory or mixed functions, which are closely related to the head and neck, which is the main or one of the main components of hand. That's why we have dedicated one lecture for this. In the upcoming weeks following the neural contents, there will be dedicated lectures for the eye and optic nerve, and there will be also another topics or lectures for the ear and vestibulocochlear nerve. Okay, so the objectives of today's lecture is to look into the functional components of the selected cranial nerves, sensory motors, and also to the central processing pathways of the selected cranial nerves. Most importantly, it's about the sensation and motor innervation of the face. So before we start with the classical lecture, this is a clinical scenario just to have an idea about what to expect whether in team report or in the end of semester exam. A 26-year-old woman developed pain behind her left ear. So her left ear, there is pain behind her left ear one evening. And the next day, she noticed that her left ear, she noticed that her left face drooping. In addition, so left face is drooping. In addition, her left ear was sensitive to loud sounds. So, on examination, the patient was conscious, had paralysis of the muscles of the facial expression of the left side of her face. Okay, she has no significant past medical history, so no diabetes, no hypertension, no heart disease, nothing to mention here. And also her physical examination is within normal, temperature normal, blood pressure 120/80, pulse 65, and respiratory rate is 12, all within normal levels. So based on the signs and symptoms, where is the lesion, where we expect the lesion is, and what is the most likely diagnosis. Okay, so in this lecture, at the end of this lecture, we should be able to interpret what's going on and be able to identify the lesion, the location of the lesion, and most likely diagnosis. In this slide, this is a quick revision of what we have done previously about the location of the cranial nerve. So if you look into the image on the left side of the slide, this is an anterior-inferior view of the brainstem, where we can see most of the cranial nerves. And on the right side image, it's a much more lateral view of the brainstem. So if you look into the image on the left side, you can see this is cranial nerve 2. Okay, cranial nerve 1 is much more superior, which is has been cut in this image. Cranial nerve 3, which is this one here, this is the location of the, see, if you look, this is the cerebral peduncle or cross cerebri of the midbrain. So the midbrain level will be here, the pons is here, and the medulla is much more inferior. So if you look at the level of the midbrain, you can identify cranial nerve 1, sorry, cranial nerve 3 oculomotor, and also cranial nerve 4. See this little fellow? This is the only cranial nerve which arises from the posterior surface of the brainstem, most specifically from posterior surface of the midbrain, but wraps around and appears anteriorly. So this is cranial nerve 4, which is also called trochlear nerve. Once you come to the pons, you should be able to identify the middle 4 pairs of the cranial nerves. Cranial nerve 5, trigeminal, 6, abducens, much more anteriorly at the junction between pons and medulla. And if you, cranial nerve 7 and 8 here, which should be much more available on or easily visible here. So this is cranial nerve 6, 7, 8. And when you jump into the medulla, you should be able to identify the lower 4 pairs of cranial nerves. If you look here anterior, this is the pyramid and the olives behind it. It's also here, this is the pyramid and the olive. So behind the olive, there is the location of cranial nerve 9, 10, 11, glossopharyngeal, vagus, and accessory. While the hypoglossal or cranial nerve 12 is the only one which appears anterior to the olive at the groove between the pyramid and the olive. All this information has been covered in previous weeks, and I assume that you know them very well by this time. Okay, so let's jump into the first cranial nerve here, trigeminal nerve. Trigeminal nerve has both sensory and motor function. Okay, starting with the sensory function of the trigeminal nerve, in week 2, we said that there are 3 main divisions for trigeminal nerve. These include the ophthalmic, the maxillary, and mandibular. These 3 divisions supply the face, the sensory, or carry the sensory input from the face. And as you can see, the representation here, ophthalmic supply most of the forehead, the nose, and the junction is around the zygomatic region. Maxillary, mostly of the zygomatic area, and the mandibular inferiorly. Keep in your mind that the angle of the mandible receive innervation from C2 nerve, not from, or cervical 2, not from the trigeminal. Okay, what else? In addition to the sensory input from the face, trigeminal nerve is responsible to carry sensory input from the dura mater. Okay, all these bluish colors from the paranasal sinuses. Remember, we've got 4 pairs of paranasal sinuses, like frontal, sphenoidal, and ethmoidal, as well as the maxillary, which are not shown here. Also carry sensory inputs from the wall of the nasal cavity, as well as, so this is the nasal cavity, as well as the mucous membrane, the oral mucous membrane, or mucous membrane of the oral cavity, including the anterior general sensation from the anterior 2/3 of the tongue. I assume that all these have been quickly or have been discussed in previous weeks. That's why this lecture just summarizes the information from different weeks in one PowerPoint. Now, We remember that we've done the DCML and STT, the dorsal column medial meniscal pathway and lateral spinothalamic tract, and we said that these are responsible to carry sensory inputs from the body, all the way from the foot, all the way to the cervical region, towards the brain. But from the head, from the face, we've got two similar somatosensory pathways, and these have been also covered in the workshop last week. This includes trigeminal touch and trigeminal pain pathway. Okay, so what about trigeminal touch pathway? Trigeminal touch pathway is responsible for processing of fine touch, vibration, two-point discrimination, and proprioception input from the face. Okay, so this pathway should be similar in function to what other pathway that we covered previously? DCML or STT? What do you think?
DCML.
DCML, thank you. So DCML. So this trigeminal touch pathway should be similar to the DCML in its function, carrying sensory inputs or type of the sensation, but in a different region of the body. Because it's a sensory pathway, there should be three levels of neurons: first, second, and third order neuron, as we learned previously. The first order neuron, its nerve cell body should be in trigeminal ganglia. Remember, DCML is dorsal root ganglia. This one is trigeminal ganglia. So the first order neuron enters via the trigeminal nerve at the level of midpoints. Once it enters at the level of midpoints, it synapses with the second order neuron at the main sensory nucleus of trigeminal nerve. Okay. Then the second order neuron will decassate to the contralateral side and descends all the way up towards the thalamus, where it synapses with the third order neuron at VPM nucleus, ventro-posterior-medial nucleus. Can anyone remind us about the nucleus in the thalamus that represent the synapse between second and third order neuron for DCML? What we call the synaptic nucleus between second and third order neuron for DCML. Is it VPM or something else? VPL. Thank you, Sam. So in the DCML, the nucleus that represents the synapse between second and third order neuron is VPL, ventro-posterolateral. Here is ventro-posterior-medial. And then from there, fibers should be projected to the primary somatosensory cortex. If we look into the somatosensory cortex, and based on homunculus somatotopic representation, where do you think the third order neuron should be ending? In the medial side, or superior, or superolateral, or most lateral side of the primary somatosensory cortex? So it's responsible to carry sensory input from the face. So the neuron should be ending at which side or which surface of the primary somatosensory cortex?
Lateral.
Lateral? Which?
Lateral.
Yeah, yes, Serena. So which lateral? Like superior lateral or much more lateral?
Superior lateral.
Superior lateral. So if you remember the homunculus, we've got the lower limb here on the medial side, trunk. And as we are moving much more lateral or superior lateral, there will be a representation of the upper limb and hand. And on the most lateral side, there will be a representation of the face and the tongue. So Serena, we're very close here. See this one, the green color? This is on the lateral side, just superior to the lateral sulcus or lateral fissure. Okay. Let's look into the next one, next pathway, which is trigeminal pain pathway. So it's responsible to carry pain and temperature input from the face, which should be similar to lateral spinothalamic tract. Okay. The first or the first or the cell body for the first order neuron will be the same trigeminal ganglia. In STT, it was dorsal root ganglia. It's the fibers will enter via trigeminal nerve exactly at midpoints. But if you look here, once it enters into the midpoints, it will descend inferiorly, go downward, and synapse with the second order neuron at the spinal nucleus of trigeminal nerve at the level of medulla. Okay. Sometimes the spinal nucleus is also called accessory trigeminal nucleus, because for trigeminal nerve, it has two sensory nuclei, main sensory nucleus, which is at the same level of midpoints, and accessory or spinal nucleus at the level of the caudal, medulla caudal, referring to the lower parts of medulla. Then at spinal nucleus, we've got the second order neuron decussate and ascends all the way up towards the thalamus, where it synapses with the third order neuron at the VPM nucleus, similar to trigeminal touch pathway, and projects to the most lateral surface of the primary somatosensory cortex. So basically, from here all the way up, it will be similar to the trigeminal touch pathway. The main difference here is the synapses between the first and second order neuron, level of synapses and level of decussation, obviously. Any question about these two pathways? Have you managed to draw this pathway well on the somatosensory workshop? Because we've covered these two pathways during the tutorial last week. So hopefully you all are able to identify or draw the individual nerve cells, make notes about the location of the nerve cell bodies, okay? And also to them, I've mentioned to the blended group that I taught on Friday that I suggested to them to make a table, comparative table of these four pathways. So put all the for DCML, STT, trigeminal touch, trigeminal pain pathway in the table and compare them according to the first order neuron, second order neuron, third, the level of decussation, the function of each pathway, depending on the body components that it's responsible to carry sensory input from them. If you make this table, comparative table, it will be much easier for you to draw the pathway for the relevant track for the questions for when you've got a question in exam. So if you wanted to make an attempt, make this table, post it on the discussion forum for week 6 or 7. I'll be monitoring both, and we can all work together to have a full answer to that table. All right. A clinical condition related to inflammation of trigeminal nerve, which is called trigeminal neuralgia, which characterized by brief attacks of excruciating pain, severe throbbing pain triggered by tactile stimulus. By some touch stimulus, there will be excruciating pain. It may involve one or more division of trigeminal nerve. It might be located to one division or more, depending on the location of the inflammation. So here, in this image, just showing you some signs, symptoms for that pain, and there is a link inferior. You can click on it if you want to know more details. But I wouldn't expect from you to know more details beyond what is mentioned in these slides for hand purpose. Most cases treated pharmacologically with sedatives. However, severe cases may require surgical intervention by cut the affected nerve if there is no response to the pharmacological medication. Now, how about the motor aspects of or motor innervation of the trigeminal nerve? If you look here, we said motor innervation of mandibular division of trigeminal nerve because, and again, from our knowledge from the first few weeks, we know that the mandibular division is the only division of trigeminal nerve which has motor function, while ophthalmic and maxillary pure sensory. So the cell bodies located within the trigeminal motor nucleus in the pons. So the motor nucleus of trigeminal nerve is located in the pons, next or close to the main sensory nucleus of trigeminal nerve. It innervates muscles of mastication. We've covered this in week 2, specifically, week 1 plus week 2. And also, in addition to muscles of mastication, it innervates a few other muscles, like the anterior belly of digastric muscle. So this is the digastric muscle. Digastric refers to as two bellies muscle, one of the muscle of the suprahyoid group. So it innervates the anterior belly of digastric muscle, and also tensor tympani muscle, which is one of the muscles of the middle ear. We'll discuss it in more depth in the last topic when we discuss the ear function or ear cells. Okay, so that was a quick revision about the motor function of the mandibular division of trigeminal nerve. Do you have anything or any question related to trigeminal before we move into the facial? Thumbs up. Continue. Okay. Facial nerve. Facial also is a sensory and a mixed nerve with both sensory and motor function. Starting with the motor function, we said previously that facial nerve responsible to innervate the muscles of facial expression. Remember, trigeminal, or more specifically mandibular, is for muscles of mastication, while facial responsible to innervate the muscles of facial expression. The nerve cell bodies, or the facial motor nucleus, or nuclei actually, located within the caudal pons. So actually there are two facial motor nuclei. One is responsible to innervate the upper muscles of the face, and the other facial motor nucleus is responsible to innervate the muscles in the lower half of the face. But basically, when you look on them, there are these two motor nuclei located in one region referred to as one facial motor nucleus. I'll explain to you why we've got two facial motor nuclei later on. In addition to innervation of facial expression muscles, the facial nerve innervates stapedius muscle, and this is via a smaller branch of the facial nerve once it passes through or exits from the facial canal, passing through the tympanic region. Okay. Now, this is slide number 13. It's explained to us a correlation between motor and sensory nerves in relation to specific body parts. So this is not a sensory pathway or a complete motor pathway. It's a reflex type. So when we have a reflex, like muscle reflex, it indicates that there is a sensory stimulation for that, which produce motor response. When you touch hot pot and you withdraw your hand quickly, so this is touch, or it's not touch, it will be temperature. High temperature will stimulate a contraction of the muscles of your upper limb so that you avoid the danger. Here we've got something similar scenario. In the situation when we trigger or stimulate the cornea, okay, that produce blinking as a motor output. So the components of the corneal blink reflex include the following. When you touch the cornea by a piece of tissue, it will stimulate the trigeminal pain pathway that we've just explained in the previous few slides. So the information, see the first order neuron of trigeminal pain pathway is going all the way, entering into mid-pons, and the nerve will continue all the way to be synapses at the level of caudal medulla. Now, part of this will go all the way up to the brain as part of trigeminal pain pathway. But at the same time, and to avoid or to provide a quick reflex, you can see that information from the first order neuron here from the trigeminal nerve will go via interneuron to stimulate the facial motor nucleus, both on the right side and left side. This is the facial motor nucleus. and this is the facial nerve. Sorry, this is the facial motor nucleus, and the blue lines represent the facial nerve that will go all the way to supply or innervate orbicularis oculi muscle, one of the muscles of facial expression that produce blinking. Okay, so corneal blink reflex can be tested as part of the neurological exam. The sensory arm or sensory inputs coming via ophthalmic because division of trigeminal nerve. This is the afferent or sensory arm, and the motor represented by the facial nerve. If you look here, if you test one in the normal situation, if you test one cornea, it will produce bilateral blinking because you can see here we've got interneuron that connected to both right and left facial nuclei, which eventually produce bilateral blinking. If you test the other eye, it will have the same output, which is bilateral blinking. And this can be used, this test can be used to do as part of neurological examination. So what happens if, like, for example, if there is damage into, if this is the left side and this is the right eye and this is the left eye, there is damage into the left trigeminal nerve. It means that by touching the left eye, but with the tissue, there should be nothing, no response, because this pathway, the main pathway that trigger both motor output, has been blocked. So by touching this and damage of the left trigeminal nerve, there should be no output. But if there is damage into the left facial nerve, by touching the left eye, the information come all the way here and go up to here. The information from there going all the way up produce right eye blinking. But here it goes through the facial nerve. When there is damage here, it won't reach into the left eye, and so on. That's why we use this as part of the routine examination, neurological examination. And I put two scenarios for you to think about and try to interpret what's going on. So what happens when stimulating the right cornea with a piece of cotton, the left eye blinks, but the right eye doesn't. So it means that if we flip the sides here, this is the right eye, what it's doing, stimulating the right cornea with a piece of cotton, okay? The left eye blinks, but the right eye does not. So if you stimulate this eye, it produces blinking on the contralateral eye, but the same eye won't blink. So do you think the damage in the sensory part, which is trigeminal nerve, or the motor part, which is the facial nerve? If you test the eye, the other eye blinks, but not the same eye. Motor, thank you, Margarita. So you think it's the motor eye. So if it is, sorry, the motor part. If the motor part is affected, will it be the right facial nerve or the left facial nerve? Will it be on the same side, facial nerve affected, or the contralateral side?
Same side.
It's the same side, yeah. Because if you look here, it's saying that testing the right cornea produce blinking of the left eye, which means that if you test this one, information come all the way here, going up, this will continue as it is because it's intact, that's why it produces blinking, but the ipsilateral facial nerve is damaged, hence there is no blinking. The other scenario is when stimulating the right cornea with a piece of cotton, so I still will consider that this is the right side, stimulate the right cornea. Both eyes do not blink. There is no blinking, but when stimulating the left cornea, both eyes blink. So what's the situation here? Damage into the motor or sensory component? Sensory, beautiful. Because here, if there is damage into the right trigeminal nerve, by testing the right eye, nothing goes into the brainstem. So we expect no output. But if you examine the other eye, which is intact, where we've got the trigeminal nerve is intact, it will produce bilateral blinking. So we know that the motor components working fine, but the problem is with the sensory components of the tested eye. Have a thought about it again after the lecture and post any question you may have on the discussion forum. Okay. In addition to the motor function of the facial nerve also provide sensory input, taste sensation, to the anterior 2/3 of the tongue. So it carries the taste sensation from the anterior 2/3 of the tongue. In this slide, we also put the sensory or taste sensation from the posterior 1/3 of the tongue, which is carried via the glossopharyngeal nerve, while from the epiglottis, the sensation or spatial sensation from the epiglottis just behind the posterior third should be carried via vagus nerve. How we test for that? We treat the tongue as two halves as well. So ask the patient to protrude the tongue and use different test substances like sweet, sour, salty, and so on. We apply it on one side of the tongue and ask the patient about what they feel or what type of sensation they feel, and accordingly we can produce a report. Reminding you that the trigeminal nerve is responsible to carry general sensation from the anterior 2/3 of the tongue, while glossopharyngeal responsible to carry also general sensation from the posterior third of the tongue, in addition to spatial sense. Okay, now let's discuss an important branch from the facial nerve. So previously we said that both the facial nerve and vestibulocochlear nerve will enter the skull via the skull foramen, which is called the internal acoustic meatus or internal auditory meatus. Once it passes through the petrous part of the temporal bone, the facial nerve will go through a canal which is called facial canal. Okay, so they split because vestibulocochlear nerve will go into the organ of hearing and vestibular or vestibulocochlear will be discussed later on, but the facial nerve will go through its facial canal. As it passes through its facial canal, it will give off an important branch which is called chorda tympani. The chorda tympani passes close to the tympanic membrane, which is the membrane that splits the outer ear from the middle ear. And then it exits at the base of the skull to enter the infratemporal fossa, where it goes. Let's see. So this is another image for the facial canal. You see this is the facial canal. We know that the facial canal exits the skull inferiorly through what is called stylomastoid foramen that have been discussed previously. But for the chorda tympani, it's going or it's exiting the skull through the infratemporal fossa and going all the way to join this branch, which is called lingual branch. This is a branch from the mandibular division of trigeminal nerve. We just previously said, if you go back here, that the general sensation of the anterior 2/3 of the tongue is provided or is carried via the trigeminal nerve through this nerve. This nerve is called the lingual nerve. So the chorda tympani will need to join the lingual nerve to be able to carry the spatial sensation, taste sensation from the anterior 2/3 of the tongue. This is one of the reasons why the chorda tympani will join the lingual nerve to reach into its destination, which is the anterior 2/3 of the tongue. So it's like two nerves combined together to reach into that particular region of the tongue. So the chorda tympani responsible to carry taste or have taste fibers to the anterior 2/3 of the tongue for taste sensation. And also, if you look here, this is going into the submandibular ganglia. So it carries preganglionic parasympathetic to mandibular ganglia to supply the submandibular and sublingual salivary glands. Remember, in week 2, we said that there are 3 pairs of salivary glands: submandibular, sublingual, and which other one, which is located much more laterally or just anterior to the ear? Can anyone remind us of the third pair of salivary gland?
Parotid.
Parotid. Thank you, Serena. So we've got submandibular, sublingual, and parotid salivary gland. So the chorda tympani carries preganglionic parasympathetic, which means secretomotor. It produces secretion to the submandibular ganglia to supply the submandibular and sublingual salivary glands. Secretomotor. Okay, what else? Let's look into this parasympathetic function in much more details here. So parasympathetic components of the facial nerve. If you look here superiorly, this is a specific nucleus which is called superior salivatory nucleus at the level of pons. Okay, there is a specialized nucleus which is called superior salivatory nucleus. Preganglionic fibers neuron resides in the superior salivatory nucleus in the pons, which eventually goes all the way to innervate the submandibular and sublingual salivary glands via submandibular ganglia. This is from the previous slide. In addition, from there, there is preganglionic fibers should goes into the nasal and lacrimal glands, via pterygopalatine ganglia. There is a ganglia which is located within the pterygopalatine fossa. Remember this fossa from week 1. And from there, the postganglionic fibers should goes into the nasal as well as the lacrimal glands for their secretomotor functions. If you go back into the textbook, you'll find way much more details about this information, origin, how it goes, type of the fiber, blah, blah, blah. A lot of information there. For hand purpose, I wouldn't expect from you to know what more beyond what is included in these slides for this lecture specifically. So we've covered the motor, we've covered the sensory, we've covered the motor, we've covered the spatial sensation, we've covered the parasympathetic component of the facial nerve. The last component here is about the somatic sensory. For the facial nerve, it carries sensory input from a small area of the skin behind the ear. And if you go back into the clinical case at the beginning of the lecture, you should find some correlation on the signs and symptoms of the lady that she had developed prior to development of the paralysis of the face. Okay, let's jump into the glossopharyngeal nerve, the third nerve in this lecture. It also has both sensory and motor components. General-visceral afferent, or GVA, carries pain, temperature, and touch from the oral cavity, including the tonsils, all this region in yellow color, tympanic cavity, as well as eustachian tube, or pharyngotympanic tube. The information comes via glossopharyngeal nerve via synapses at the spinal trigeminal nucleus, at the lower parts, the spinal nucleus of trigeminal nerve. So this spinal trigeminal nucleus has dual function. One part is part of trigeminal pain pathway and also represent a synapse for the sensory inputs carried via glossopharyngeal nerve. It also carries input from the carotid sinus, carotid body, baro, and chemoreceptor. And the nucleus for these functions represented by the nucleus of the solitary gland, nucleus of solitary tract, okay, which is a relatively large nucleus spanning through the rostral, medulla, and caudal pons. Spatial sensory, which is responsible for carrying of sensation or spatial sensory of taste from the posterior 1/3 of the tongue. The synapses here through the nucleus of solitary tract as well. Again, similar to the previous slide, much more details included in the relevant textbook. You are very welcome to go there and look for more details. But for hand purpose, for assessment purpose in hand, I wouldn't expect from you to know more beyond this. A clinical condition similar to trigeminal neuralgia, here it's called glossopharyngeal neuralgia, which characterized by attacks of pain begins in the posterior parts of the tongue and or the pharynx in response to tactile stimulation. So in response to swallowing or ingestion of the food, there will be pain in the posterior parts of the tongue and the pharynx during swallowing, which might occur due to inflammation of glossopharyngeal nerve. What other function of a glossopharyngeal nerve? Parasympathetic function, or GVE function. Let's look where we can. So the information of the relay nucleus here is inferior salivatory nucleus, not superior salivatory of the facial. This is the inferior salivatory nucleus, which is located at the rostral medulla. So in the rostral medulla, there is also a specialized parasympathetic nucleus, which is called inferior salivatory nucleus. If you follow the fibers going all the way like this and go eventually into the parotid gland. So remember, facial nerve provide facial nerve provide parasympathetic function to the submandibular and sublingual salivary gland through submandibular ganglia. Sorry, I can't drink water. But for the glossopharyngeal nerve will eventually innervate, provide parasympathetic function to the parotid gland is through what? What is called otic ganglia. So please make a note about the relaying ganglion, the nucleus and ganglion for innervation of parotid and submandibular and sublingual salivary glands. Also provide branchial, motor, branchial like visceral motor function, which is originated from another nucleus here in the medulla. This is called a nucleus ambiguous. Ambiguous represents vague nucleus. It's a common motor nucleus for three cranial nerves: glossopharyngeal, vagus, and accessory. And through nucleus ambiguous, vagal glossopharyngeal nerve should be innervating stylopharyngeus muscle that elevates pharynx during swallowing and speech. So it contributes to the process of swallowing and speech production. Okay, before we come into the next topic, do you have any question about what have been covered so far? All right, let's move into the second part of the lecture here, which will be about introduction to the motor pathway. Next lecture will be about the motor pathway, so we'll discuss the detailed components of the motor pathway. Here, this is mainly related to the motor pathway that originated from the cranial nerves. And before we know more details about this pathway, which is called corticobulbar tract, I just wanted to provide you with a brief introduction about the motor pathway. So in the sensory pathway, we said we always start from the peripheries, from the sensory, going all the way to the brain. Motor pathway, we need to start from the brain, more specifically from the precentral gyrus. Remember, engine of the car, motor of the car, always in the front. So the precentral gyrus within the frontal lobe is also functionally named as the primary motor cortex. So the information should originate from there and going all the way to the peripheries. There are two main pathways, corticobulbar tract and corticospinal tract. There will be a series of additional pathways that will be included in the lecture of motor pathway, but for this scenario, we'll stick with these two. So motor sensory consists of three neurons, first, second, and third. The first will be the one starting from the peripheries. Third, the one should be ending or terminating at the primary somatosensory cortex. Motor pathway, they have two neurons. These are referred to as the upper motor neuron. So the upper motor is the one that starts from the precentral gyrus, specific region of precentral gyrus, and going all the way to synapse with the lower motor neuron. In the corticospinal tract, the synapse will be at the level of spinal cord, and we'll discuss the details. There will be lower motor neuron, which is the spinal nerve. But here, in the corticobulbar tract, the synapse will be at the level of a brainstem because it needs corticobulbar is the pathway that eventually responsible to activate of muscles which are under the control of the cranial nerves, like muscles of facial expression, as an example. Okay, that's why if you look into the corticobulbar tract, the upper motor neuron start from the precentral gyrus, and if you look here, it starts more specifically from the most lateral surface of the precentral gyrus, where we've got representation of the head and or face and the tongue, and going all the way to supply the cranial nerves with the motor nuclei. So at the midpoints, it supply the, for example, it is not here. At the midpoint, it supplies the motor neuron of trigeminal nerve, which supply muscles of mastication. Also at the level of midpoints, where we've got the caudal points, where we've got the motor nucleus of the facial nerve. Remember, we've got two nuclei, one responsible for upper face, one for lower face. It's also responsible to provide bilateral innervation to the upper motor nucleus of the facial nerve, but only contralateral to the lower face. And then when it goes into the medulla region, to provide bilateral innervation to the other cranial nerves, lower cranial nerves with the motor inputs, like glossopharyngeal or vagus, accessory, and so on. Okay, so in summary, and the lower motor neuron will represent the cranial nerves with the motor function, like the facial nerve, represented by the lower motor neuron. So again, quickly, the corticobulbar tract, important influence on the lower motor neuron nuclei of the facial nerve with motor function. This is specifically included trigeminal, facial, glossopharyngeal, vagus, accessory, and hypoglossal, which control many muscles of the head and neck. For cranial nerve 3, 4, and 6, these are three cranial nerves related to the movement of the eyeball. I won't cover them here. Richard Fernandez will be covering them when he talks about the eye region. So for corticobulbar tract, responsible for motor output or motor control of these cranial nerves. The first neuron is called upper motor neuron, which start or cell body start from the primary motor cortex, coming all the way. Fibers travel through the internal capsule, specifically near the genu. It's posterior limb near the genu. Some textbooks saying just the genu. Other textbooks saying that the interior part of posterior limb plus the genu. Okay, for hand purpose, I will accept the genu for all answers. And if you say interior parts of the posterior limb or posterior limb near to the genu, I will accept this answer as well. So it passes through the internal capsule and through the crus cerebri or cerebral peduncle, CP, then passes through the basal pontis and passes through the pyramids of the medulla. Okay, so this is the basal pontis and then the pyramids of the medulla. Remember, these fibers always anterior, motor of the car, engine of the car, always anterior. So these fibers travel much more anterior location as compared to the sensory fibers that are located much more or laterally or behind, posterior to these fibers. So generally speaking, the upper motor neurons innervate brainstem lower motor neurons bilaterally, as we said. See, 1, 2, right, left, except the lower face. right leg for the lower cranial nerves. But an important exception here, which is for the upper half of the face, it received bilateral innervation, but for the lower half of the face, it received contralateral innervation. As you can see here, this is, we just enlarged this, zoomed in, bilateral to the upper half of the face, but contralateral to the lower half of the face. And this has a clinical implication. While for the lower motor neuron innervation, always it's lateral. So what does this mean? If you look here, this is part of the corticobulbar pathway, which goes all the way to the muscles of the facial expression. So the upper neuron is coming here, although I see this is the neuron coming from the upper half of the face, and this is neuron coming from the lower half. Both of them part of the corticobulbar, but showing you two fibers, one from the upper half, one from the lower half. And this is from the upper half only. If you look into the upper half of the face, going all the way, synapses into the facial nerve that, or motor nucleus of the upper half of the face, and then we've got the facial nerve fibers that goes all the way to the upper half of the face, which means that if there is damage into the right upper corticobulbar tract or the left corticobulbar tract, eventually the patient can still control the muscles of the upper half of the face. But the exception here is that the lower half of the face receive only contralateral innervation. So if you look, this is the right side, the fibers coming from the lower half or responsible for the lower half of the face, going all the way to supply contralateral side, which eventually going into the lower half of the face of the left side. So it means that there is damage here into the right corticobulbar tract. It means that there will be paralysis of the lower half of the face on the left side, which is represented here. So when there is upper motor neuron lesion, patients will have contralateral paralysis of lower half of the face. However, this is the first scenario. However, if the lesion is in the lower motor neuron, which means that the facial nerve itself has been damaged. Hence, there will be no innervation, there will be loss of innervation to both the upper and lower half of the face of the affected side. So if there is left facial nerve palsy, it means that the patient will have complete paralysis of that half of the face. Okay? Let's repeat this in different words. So unilateral lower motor neuron or facial nerve damage causing entire ipsilateral face paralysis. This is a clinical scenario referred to as Bell's palsy. Sometimes there might be partial damage into the facial nerve. Hence, the patient may not have complete paralysis of all the muscles, depending on the severity of the damage. While unilateral upper motor neuron damage, it produced contralateral lower half of the face paralyzed. So again, if you go back here, this is what it's a summary of these two situations. In both situations, there will be leaky mouth when there is paralysis of the lower half of the face and speech difficulties, lack of blinking reflex in lower motor neuron, and lacrimal fluid production, parasympathetic damage or loss of the parasympathetic function of the facial nerve, which may cause drying of the eye and risk of corneal damage. This last one can occur when there is Bell's palsy, when there is complete paralysis of one half of the face. So if you look into this image, what type of lesion side does the person shown here? So if you look here, the female here has been asked to frown her head and smile. Do you think that which side of muscles have been affected? The right side here or the left side? Right side, beautiful. When you look into the right side paralysis, do you think it's a complete paralysis of the right side or just the lower half of the right side? See the wrinkling here as compared to here, complete. Beautiful, thank you. So this woman has a complete paralysis of the right side of the face, so it fits really well with Bell's palsy or facial or right facial palsy. Now, what I'm asking from you is to go back into the clinical scenario at the beginning that we've covered or mentioned in the beginning of the lecture, and have a thought about it, think about the progression, and post your comments into the discussion forum. Do you have any question to me before we close the lecture? I'll just stop the recording now.